This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hey, this is Jason Crowell from Norton Neuroscience Institute in Louisville, Kentucky. Today, I have the pleasure of welcoming David Lynch to the podcast. David is a neurologist at the Children's Hospital of Philadelphia. He is the director of their Friedreich Ataxia program. David, thank you for joining us today.
Thank you, Jason, for having me come.
So we saw this headline a few days ago and said that we wanted to talk to you about this. We're so glad that you joined us. There's a new drug approved for treatment of individuals with Friedreich Ataxia. The name of the drug is Omaveloxolone. And so when we saw this news, we wanted to make sure our audience was aware about this. So in this conversation, I think there's maybe two stories here. So there's the story about this new disease-modifying treatment for Friedreich Ataxia, of course, but then there's also, I think, an interesting story about how this drug actually sought its approval. But let's start with the headline. So can I ask you, David, to just give us a very brief overview of Friedreich Ataxia? So keep in mind that we have a wide audience here. We have medical students, neurology trainees, practicing neurologists, specialists. Would you mind giving us a quick overview of this disease?
Friedreich Ataxia is a rare, progressive neurodegenerative disorder affecting about 1 in every 50,000 to 1 in 100,000 people in the United States. So we think there are about 5,000 people in the United States with Friedreich Ataxia. In its most typical form, it begins between ages 5 and 15 with difficulty walking, which slowly progresses over time to being 10 to 15 years after presentation, becoming unable to walk, but with associated loss of coordination in the upper extremities, loss of speech function, and in a few individuals, loss of vision as well. In addition, there's early mortality in Friedreich Ataxia. About 50 to 60% of people die young to a progressive cardiomyopathy. As I mentioned, almost everyone presents to a neurologist first, although a very few people will present to cardiologist first, or occasionally to an orthopedic surgeon based on scoliosis.
And what is the typical genetic cause of this disease?
Friedreich Ataxia is an autosomal recessive single gene disorder. Everyone has mutations in the gene we call the FXN gene, or frataxin for short. This gene that encodes a small mitochondrial protein called frataxin, which controls energy production in the cell. So essentially, Friedreich Ataxia is a form of mitochondrial disease, but it's autosomal recessive. Most of the mutations, 96% of them, result from a downregulation of transcription in the gene, so you don't produce as much mRNA, and thus not as much frataxin protein. In about 4% of individuals, the mutation is something where you don't make protein directly. Start codon mutation, a mutation which gives rise to misfolded protein. So all of the mutations give rise to the inability to produce functional frataxin, or at least relative inability to produce functional frataxin.
All right, very good. So now tell us about this new drug that was just FDA approved, Omaveloxolone. How does this drug work? How does it help patients with this disease?
Omaveloxolone, or OMAV for short, is a drug that upregulates the transcription factor NRF2, also called NRF2. NRF2 is in charge of your body's response to mitochondrial dysfunction, to reactive oxygen species production. So you would think that in Friedreich Ataxia, being a mitochondrial disease, it would be upregulated. In fact, it's not. It's paradoxically downregulated and mislocalized in the cell. So when you look at cells from people with Friedreich Ataxia, they're not making enough of the endogenous response to mitochondrial challenges. They're not making enough response to free radical production. As a result, that causes some component of the disease. And this drug, its goal is to increase the NRF2 levels, which are paradoxically downregulated. So that's the strategy behind it. It's based on a lot of cell models and some animal models in particular.
The frataxin gene that is insufficiently producing its protein in someone with Friedreich Ataxia, this drug is not actually working on that protein, right? It's on a different protein that has to do with mitochondrial repair. Is that fair?
Yes, Jason, that's fair. This drug does not act directly on the frataxin gene. It acts on downstream processes from that. So it's likely to be a beneficial treatment, but it will not restore frataxin completely, and thus is not likely to be an absolute cure.
So when we were looking at data about this drug back in October of 2020 in Annals of Neurology, David was the lead author on a paper titled Safety and Efficacy of Omaveloxolone in Friedreich Ataxia. And David, my understanding is that this is the paper that demonstrated safety, but also improvement in a rating scale, the modified Friedreich Ataxia rating scale. So what does this scale measure, and how clinically significant were the improvements that were seen in that study?
So the modified Friedreich Ataxia rating scale, or mFARS for short when you read about it, is essentially a quantified neurological exam directed to the components of neurological dysfunction that are most affected in Friedreich Ataxia. So it's heavily weighted toward gait and stance, but also has features of lower extremity function as well as upper extremity function and a little bit of speech. It doesn't include any of the neuromuscular functions, as typically the FDA doesn't judge those to be relevant to patients. So it focuses on those things which are most affected in FA. It changes in a large natural history study, which we've been running now for almost 20 years. It changes on the order of 1.5 units per year in a group which would match that enrolled in the clinical trial. In the clinical trial, the difference between the placebo group and the active drug arm was about 2.5 units of improvement. So you could say that the benefit is about 1.5 to 2 years worth of progression. Is that clinically meaningful? I would dare say that to a patient, it certainly is. This is a relentlessly progressive disease. And if you ask them every year whether they are worse than the previous year, they will always say yes. So if you say you're going to go back 1.5 or 2 years in time, that is clinically meaningful.
David, that was essentially a phase 2 study. So how did we get from that phase 2 study to getting this FDA approval? You mentioned the natural history study. Can you tell us more about why was that route pursued rather than a typical phase 3 trial? What's the story there?
This drug is approved after what is nominally called a phase 2 study. I think many people don't realize that there is actually no requirement to go to phase 3. What you have to have is compelling evidence. And in rare disease, and Friedreich Ataxia is considered a rare disease, and thus Omaveloxolone becomes an orphan drug, you're allowed to get away with one study if it answers all the relevant questions. That's very hard to do. You need a lot of safety data, you need a lot of pharmacokinetic data, and you need really tight data. The first study on its own, the double-blind study which showed the improvement in the mFARS, was not judged on its own sufficient to make it an approvable drug. But it did have an extension phase, which allows the opportunity for a second study. In that second study, it was evaluated in 2 ways. First, you were able to compare the people who, in the extension part of the study, those individuals who had been through the double-blind phase, and then everyone went on active drug. You could compare those individuals who started initially on active drug versus those who were initially on placebo. And what you see is that the difference between the groups in so-called delayed start analysis persists after the time where everyone goes on drug. That is consistent with a disease-modifying activity that says the drug is stabilizing the disease and or reversing or slowing progression. So that delayed start analysis is component number 1. But courtesy of a long-running natural history study in Friedreich Ataxia, the so-called Friedreich Ataxia Clinical Outcome Measure study sponsored by the Friedreich Ataxia Research Alliance, we now have natural history data on roughly 1,400 individuals, some of it going as long as 20 years. We are thus able to take a propensity match cohort where you match across 5 variables within that natural history group and compare them to the people in the study. And when you do that, you see that the overall benefit of Omaveloxolone over the course of 4 years is a 55% improvement just within the extension study. And if you add in the double-blind phase, the improvement is much bigger. So that allows you a second way to analyze it, which tips the balance and allows us to have an approvable study that shows a little bit about how important natural history studies can be to the direct approval for drugs in rare disease.
That's interesting. So I'm not too familiar with the Friedreich Ataxia Research Alliance, but I assume that this required a lot of coordination and a lot of patient participation, right? Signing up to be a part of this natural history study.
It has been very labor intensive for the past 20 years. It begins as 7 investigators in a room at a meeting in New York, and then has continued now for greater than 20 years, each of us seeing back 20 patients, 30 patients, myself and Susan Perlman, greater than 100 patients a year, and doing a series of exams every year on that and running the whole study like a clinical trial. This has required a lot of patient cooperation. We defray part of the cost of people to come see us, but it is a research visit, and the patients have been so helpful and so donating of their time to come forward. And again, I mentioned our sponsors, the Friedreich Ataxia Research Alliance, who made this a major priority with an estimated budget of greater than $1 million a year for each of the past 20 years, simply to get this data so that we would have it for clinical trials when the right drug came along.
So you mentioned earlier that the mechanism for this Omaveloxolone is not actually specific to the pathology of the disease in the sense that it's not working on frataxin. But it makes me wonder, is it possible that this drug could then be used for other diseases that similarly have mitochondrial dysfunction?
It has been attempted to be used in some other mitochondrial diseases with negative results. But in fact, the NRF2 pathway can be downregulated in a variety of different diseases. Huntington's disease, Alzheimer's disease, and Parkinson's disease. I've heard most recently about Fragile X. So the utility of Omaveloxolone in those disorders remains to be explored. Still, what I think is a critical piece in FA is not only that it is downregulated, this whole thing is paradoxical. It should be upregulated. So it tells you something about how the compensation mechanisms of the cell have gone awry in Friedreich ataxia.
All right, David. Well, this is really exciting news. I'm sure patients with this disease are super excited about this news. We really appreciate you joining us and taking some time to explain it to us.
Happy to.
David Lynch, the lead author and co-authors, is published in the Annals of Neurology. The title of the paper is Safety and Efficacy of Omaveloxolone in Friedreich Ataxia. Thanks so much for tuning in to today's Neurology podcast.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.